Thank you.
Well, certainly, it's again a privilege and a pleasure to be here. What I'll do this morning is to review some of the basic concepts related to the evolving data on preoperative treatment for pancreatic cancer, and to give you an idea of where the field is moving in North America. What I'd like to cover are some of the issues related to, first of all, the background rationale for the treatment. I'll outline our own unit's emerging results and data, and then share with you results and some preliminary information of a clinical trial that's underway being conducted by the American College of Surgeons Oncology Group, looking at a phase 2 approach using a preoperative treatment strategy. The background information, I think, is well familiar to all of you here. This is a very serious disease, and despite better understanding of the biology, as we just heard, we haven't made substantial progress over the past decade, or even arguably the past quarter of a century. If we look still at the overall survival statistics, they're quite disappointing, and as a field, we have tremendous opportunities to help patients. If we look at what's achievable now with surgery, we can summarize this in essence in a few slides that help to illustrate this, a few bullet points. We see that in most centers, mortality is something on the scale of less than 5%. Hospital stay can be as short as 7 to 10 days. Recovery is still prolonged, probably, depending on how it's measured, still measured in months. Median survival achievable with surgery, as you saw from Marcus Buechler's talk yesterday, is around 20 months, and in randomized trials is something less than 20 months, something in the range of 18 to 20 months, and long-term survival still in the range of 10 to 20%. We also understand, if we consider the universe of patients with pancreatic cancer that present to us as surgeons, that within the universe of patients that we see who have potentially resectable disease that appears localized, there is a subset of patients that have very bad biology. We don't fully understand why. We don't have an ability to identify who these patients are, but we know them when they come back to us in clinic 3 or 6 months after what we felt was a successful operation, and they have metastatic disease identified on their imaging studies, and then we understand in retrospect that that metastatic disease was present when we performed the operation, and that in essence we can't help these patients with surgery. And part of the rationale for preoperative treatment is to help us to select out this group of patients who honestly we cannot help with surgery. If they have metastatic disease identified in 3 months' time, there's very little argument that we can make that these patients are substantially improved with an operation that takes 3 months to recover from. So if we look at the underlying rationale for preoperative treatment for this disease, we can first say that there's emerging evidence from randomized trials that treatment with more than just surgery improves outcome. We see data from Europe, from both the German study and from SPAC1 demonstrating that adjuvant chemotherapy, as we saw yesterday, either 5-FU or gemcitabine improves survival compared to treatment by surgery alone. And I think in this context, it's recognized that patients need treatment with more than just surgery. We also see that in the setting of a disease that is micrometastatic in almost all patients, that a treatment approach that gives the patient chemotherapy first, in essence, treats the disease that poses the greatest risk to the patient immediately. We also saw yesterday, in the context of the discussion we had on borderline disease, that preoperative treatment may be also a strategy to improve the R0 resection rate, which is certainly the general therapeutic goal that we have as surgeons. As I just described, this approach, by delaying surgery, allows us to identify the subpopulation of patients that has aggressive disease and these patients are therefore not subjected to an operation that carries mortality risk, that carries significant morbidity, and offers them really no long-term potential for benefit. From a treatment delivery perspective, we also know from experience in this disease and others that treatment approaches where the adjuvant therapy is given before surgery, before a big operation, allows more patients to receive all components of treatment, so that if we accept the underlying hypothesis that it's better to be treated with surgery and chemotherapy, more patients will receive that combination if the chemotherapy is given before the surgery. That's well demonstrated in multiple tumor types, and particularly with this operation, which carries significant morbidity risk, and where there's a subpopulation of patients, as many as 30% or more, that do not recover well enough to receive adjuvant treatment after this operation. Now, in our institution, we've had a long history of interest in preoperative treatment, and this table summarizes several clinical trials from our institution. Obviously, I will not review them all here, but I'll focus on data from our most recent study, which was a study that combined gemcitabine and radiation. This was published in the Journal of Clinical Oncology last year. And this is the treatment approach that we used. The patients, as I showed you yesterday, undergo initial staging CT and multidisciplinary treatment planning. At that time, in this protocol, we were using a combination of gemcitabine, interestingly, relatively low dose gemcitabine combined with radiation treatment. It's an easy treatment combination to administer because the gemcitabine at this dose is extremely well tolerated. The radiation approach that we use was a therapeutic approach that would be very popular in Europe. That is high dose per fraction, short course treatment. So it's 10 days of treatment, 30 gray, administered over 10 days, 3 gray per fraction. So it's very convenient for patients. It's radiation treatment this week and next week, combined with gemcitabine, administered preoperatively over a 7-week period. Then there's a 3 to 4 week break after that, at which time patients undergo restaging, a CT scan. And this is the point, as we saw yesterday, where we identify the subpopulation of patients that has radiologically identifiable disease progression, usually in the form of metastatic disease. Those patients do not go on to surgery, and they are, in essence, spared an operation that they never would have benefited from because of this treatment approach. The group that then does not have disease progression proceeds on to surgery. If we look at the outcome data, you can see that we enrolled 86 patients to this trial. 86 patients completed preoperative treatment, again demonstrating the feasibility and the practical reality that patients tolerate this treatment much better when it's given before surgery. So in essence, we can deliver the treatment to 100% of the patients. Of that group of 86, 74 went to the operating room, 64 were resected, and interestingly, as we had talked about yesterday, in discussing pathologic response, we saw 2 cases of complete pathologic response. Importantly, there were no treatment-related deaths associated with chemoradiation treatment or surgery. This is the survival plot, which shows survival plotted out on an intention to treat basis, in essence showing the outcome for all 86 patients enrolled in the study. And you can see that even when you group the patients that didn't have surgery, this includes the ones that had surgery and the group that didn't have surgery, the median survival with this approach is 22.4 months, which compares very favorably to the 20 months that Marcus Buechler showed yesterday. When you look at the survival plotted out by those who underwent chemoradiation followed by surgery versus those that did not have surgery, you see this expected difference. Obviously, the resected patients do better than those that have liver metastases and don't have surgery. And the median survival achievable in that setting is 35 months. Again, showing that with this approach, you can achieve median survivals, as we saw yesterday, in the range of 35 to 40 months. On the surface, understanding the fact that these are single institution data and perhaps not strictly comparable to data from randomized trials, but still these numbers with median survivals in the range of 35 to 40 months appear substantially better than results obtained by surgery alone, or even results obtained in the context of SPAC, where we see median survivals of about 20 months. If we look at our ability to achieve an R0 resection, just looking at our own institutional experience, we see that this is more commonly achievable in the setting of preoperative treatment compared to post-op therapy in situations where we offered patients upfront surgery. Now, another issue that's been raised as a concern regarding the use of preoperative treatment, and this appears somewhat less and less as people gain more and more understanding of the biology issues and the practical reality that there is this subpopulation of patients that shouldn't have surgery, even though they have tumors that appear resectable at the time that they show up in our multidisciplinary units. And the concern raised is always that a delay in surgery is somehow risky for the patient, that it might compromise survival in some way, that a chance to cut is a chance to cure, and if we adopt a policy where surgery is delayed by 8 to 12 weeks, that somehow is going to translate into bad outcome. Well, we looked at this by looking at our own institutional experience and then not looking using statistical methods at actuarial survival, but looking at actual survival. And when we looked at our actual survival data from 328 patients treated over a 12-year period of time at our institution, you can see that we have a 5-year actual overall survival rate of 27% in the setting of a uniform policy of preoperative treatment. So that if this treatment approach were categorically inferior, and if there was some systematic problem and we were disadvantaging the patient, as someone asked yesterday, is there an ethical problem with a delay in surgery for this patient population? I think that these long-term data of actual survival from our institution clearly argue against that, with a 27% 5-year actual survival or 14% numbers with 10-year data. Now, there are potential disadvantages of preoperative treatment, and in the context of a fair, balanced discussion, let's look at them. When we look at this from a practical standpoint, here are some of the concerns that have been raised over the past 2 decades about this approach. First of all, to engage in this approach, you need a tissue diagnosis, and we touched on that earlier today. Biliary decompression is required, and that's an issue, as we've talked about today, and is associated with its own scope of risks and issues. We just talked about the issue of curative surgery and the delay in that as a potential disadvantage. We also have heard concerns in the past that the toxicities associated with the chemoradiation treatment may delay potentially curative surgery. We've heard concerns that local disease progression may preclude surgery, that patients may have their primary tumor grow to a point where it becomes borderline resectable or not resectable at all. And we've heard concerns that the morbidity and mortality of surgery may be increased in patients that have received cytotoxic chemotherapy, or the operation may be more difficult to perform in patients who've received radiation treatment. And if we look at the reality of these issues now in 2010, with the advent of endoscopic ultrasound and high-quality CT imaging in general, it's not difficult to achieve a pre-treatment tissue diagnosis in patients with localized pancreatic cancer. No question that biliary decompression is required, and we would agree with the comments made earlier this morning that metal stents are preferred in this setting to minimize the morbidity risk in patients that will need biliary decompression for many weeks before surgery. Well, the issue of curative surgery, I think we've discussed adequately. Yes, the curative component of the treatment is delayed, but that is not associated with any definable adverse impact for patients. We've not seen treatment-related toxicity resulting in delay in surgery, that the patient completes the chemoradiation treatment, and then because of the toxicities of the therapy, the operation gets extended farther and farther out. These patients generally recover very well from the treatment, and we've not seen substantial delays in surgery. We also see in our institutional experience with over 300 patients treated this way, only a handful of patients where we could honestly say that local disease progression was a barrier to surgery. We scan these patients with regularity, and I think that if the primary tumor grows substantially during treatment, that's clearly a sign of aggressive biology also. And indeed, we did not see any evidence that the morbidity and mortality associated with surgery is increased with this approach. In fact, we saw the opposite. When you look at our mortality data from our institutional experience, we have a 1% mortality rate associated with this type of surgery. And we found that our leak rate after radiation treatment is about 3%. And that's not because I used the microscope, but it's because the gland gets radiated and it's easy to sew to. And there may be a radiation-associated decrease in exocrine output. So that combination translates to a 1% mortality rate and a 3% risk for an anastomotic leak after preoperative treatment. Now, if we look at the status of preoperative treatment now, we see that there's compelling rationale, favorable results from single institution reports, and we see in the United States that this is moving on to a national stage. And as we alluded to earlier, this is a therapeutic approach that's widely accepted for other solid tumors such as breast cancer, esophageal cancer, bladder cancer, and rectal cancer. So the current issues then are, can preoperative treatment be administered on a larger scale, or can it only be administered in centers where there's a large multidisciplinary team that can manage these patients and all their issues together? The second issue is, in the context of the challenging biology associated with this disease, wouldn't this approach be a fantastic way for us to investigate targeted molecular therapies? And what I mean by that is, imagine if we could give preoperative molecular agent X, then perform an operation to resect the tumor. This gives us basically an in vivo assessment of the impact of these new molecular agents that are coming out every day in GI cancer. And this then permits us to assay, in a very difficult disease, what is the impact of these agents in human tumors in an in vivo system. And then we have the rhetorical question, really, why isn't this approach more widely accepted in the context of the compelling rationale that we're discussing this morning? Well, in the U.S., this is moving forward now with a clinical trial being conducted by the American College of Surgeons Oncology Group that's open across the United States and Canada. This is a study for the patient population that we're talking about with localized resectable pancreatic cancer, satisfactory performance status, and end organ function. And importantly, it's not a study for borderline or marginally resectable disease. It's not a study designed to see if this treatment converts patients from borderline resectable to resectable. This is the treatment approach used. In essence, it's a program of preoperative chemotherapy, surgery, and postoperative chemotherapy using a chemotherapy regimen of gemcitabine and erlotinib, which is an oral tyrosine kinase inhibitor. This combination has been shown to be effective in metastatic disease. The treatment details are outlined here. It's standard dose gemcitabine and a standard erlotinib administered orally each day throughout treatment. Now, an important aspect of this is that surgery is part of the trial, and in that context, this is the first trial ever in localized pancreatic cancer that will quality control the surgery. There's a protocol specified quality control to the surgery and the pathology, which by itself is a huge step forward. If we look at all the other adjuvant studies, for example, one of the issues that's been raised about the SPAC studies is the absence of any quality control for surgery as part of those studies. The sample size is 91 patients, and of course there are interim analyses and stopping rules that are included as part of the design of this type of a trial. Importantly, as we were talking about using this methodology, the correlative science studies that are integrated in the protocol are a critical part of this, and they are understandably focused on EGFR biology and of course include microarray and other biologic studies that are then done on the resected specimens using a centralized tumor banking approach. So to summarize, there are a subset of patients with localized pancreatic cancer who have disease that is rapidly progressive, and these patients cannot be helped with surgery. Our problem is that we cannot identify those patients when we first see them at the time of initial staging. The use of preoperative treatment has an underlying rationale that's very compelling in the context of a disease that's micrometastatic at diagnosis in almost everybody, and it's a treatment approach that's been used in many other solid tumors. We see favorable single institution results that I shared with you, including median survivals in the range of 35 to 40 months. And you see that in North America, this approach is moving on to a national stage in the context of the trial that I shared with you. And I'll stop there. I thank you very much for your attention.